stage is for you.
Thank you very much. My name is Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. My name is Maymoon Alhaj, a senior resident at the Ammerland Clinic in the Department of General and Gastrointestinal Surgery. It is a big honor of mine to be part of your Congress, and I will talk today about our experience and to talk mainly about the transanal total meso-rectal excision, a meaningful, safe, and feasible technique. As a background, the transanal total meso-rectal excision is an emerging surgical technique for the rectal cancer, and it has been developed to improve quality of the TaTME for patients with mid and low rectal cancer. The TaTME conventionally was first described by Hield in 1982, and since then it has been the gold standard treatment of middle and lower third rectal cancer. This sketch shows the different layers will be operated transanally. I will talk about this sketch later in my presentation. The classical transanal meso-rectal excision was done by an open anterior abdominal approach, but advances in technology and surgical techniques have enabled total meso-rectal excision to be performed laparoscopically, and the laparoscopic total meso-rectal excision to compare it with the conventional open approach has showed comparable results in terms of perioperative morbidity, surgical margins, and quality of surgical specimen, and the number of resected lymph nodes, and the local recurrence and overall survival. In addition, the laparoscopic approach was found to be associated with fewer wound infections, reduced blood loss, shorter hospital length of stay, and earlier return to normal diet and bowel function. But as the limitations of the laparoscopic total meso-rectal excision was the narrow pelvic anatomy, the male gender, and the high body mass index, and the ultra-low located lesions, as well as the high conversion rate from laparoscopic to open surgery. And these main factors have become challenges and motivated surgeons to develop alternative techniques for the treatment of rectal cancer. And in 2010 came the revolution in conducting a down-to-up procedure, but this time using minimally invasive techniques, and was conducted in 2010 by the group of Naser. I will compare shortly the transanal total meso-rectal excision versus the laparoscopic total meso-rectal excision, and I will show you the biggest study of all time that concluded all studies until 2016. This is the systemic and meta-analysis study was conducted in PubMed, Embase, and Cochrane database, and all original studies that compared the transanal total meso-rectal excision with the laparoscopic one were included. As a result, a total of 7 studies, including 537 patients, transanally 217, and laparoscopically transabdominal 303 were included. Concerning the ecological outcomes, no difference were observed in terms of arrested lymph nodes.
Can you share with us your screen, please, Dr. Maymoon? Will you share your screen with us so we can see your presentation?
Surely.
Please.
So, I will give. This is the sketch where it shows the layers that I have talked about. When we conduct a transanal total meso-rectal excision, I will talk about it later. And the systemic review system review that compares total transanal total meso-rectal excision. Is this system review, and this study included the 537 patients. Concerning the oncological outcomes, no differences were observed in harvested lymph nodes, in distal resection margin, and for all the positive distal resection margin. However, the transanal total meso-rectal excision group showed a higher rate of achievement of complete grading of meso-rectal quality, a longer CRM, and less involvement of positive CRM. Concerning the perioperative outcomes, the results for hospital stay, intraoperative complications, and readmissions were comparable between the two groups. However, the transanal total meso-rectal excision showed shorter operating time, lower rate of conversion, and a significant lower rate of overall postoperative complications. I will talk now about our experience in our clinic. We have conducted in 18 months this operation on 25 patients, and the laparoscopic transanal meso-rectal excision. The median age was 62, the median body mass index was 42.7. Pre-operative tumor staging, 22 patients with T3N+, 2 patients with T2N minus, and 1 patient with T2N+. All the T2 and T3N+ patients underwent neoadjuvant chemoradiation therapy, and the mean operating time was 306 minutes. We are, as you know, a learning curve, but we are doing a great development in our operating time. This diagram shows the post-operative staging of all patients, and the post-operative length of stay averaged 12 days, 11 days, and the post-operative pain was 3. All patients underwent the fast-track rehabilitation with mobilization at the first post-operative day. Our oncological results shows that the mean location of the lesions from the anal verge was 3.1 centimeter, range 1 to 12, and the mean upper margin of safety was 25.7 millimeter, and the determining criteria is the pathological grading of the total meso-rectal excision specimen. Revealed that 24 patients had grade 1. Grade 1 means that completely intact meso-rectal envelope, and 1 patient had grade 2, near completely intact meso-rectal envelope. All of the patients had a loop ileostomy constructed, and 12 from 25 patients had loop ileostomy closed. The remaining 13 patients, we will do the closure in the next month. We have studied the continence after the closure of the ileostomies according to the Cleveland Clinic incontinence score, and it shows that 4 patients have moderate to severe incontinence, and the rest of the patients have had excellent to good continence. And we have measured our complications according to Cleveland score into minor and major complications. Minor complications as wound infections, urinary dysfunction, urinary retention, and vaginal or urethral simple lesions or injuries. It is by, in our experience, 37% of the patients have had minor complications. Major complications such as Elias mechanical obstruction and anastomotic leak have had, in our experience, 1% of all patients. As a comparison, there was a systemic review. This is also the biggest systemic review that shows the clinical outcomes and case volume effect of transanal total meso-rectal excision until now. It was published in 2016, and it shows, in simple words, it shows the results of the whole world of the in conducting transanal total meso-rectal excision. Over 3,000 articles were included, but 33 articles fulfilled all the inclusion criteria and met no exclusion criteria and were included in the analysis. And this table shows the results of the systemic review. In simple words, the results of the whole world in conducting transanal total meso-rectal excision and our experience. In the whole world that met the criteria, there were 749 patients, and in our experience, 25. The gender, median body mass index, and the ASE classification, as well as the neoadjuvant therapy, were comparable in the two groups, and the mean operating time was 234 minutes. Our experience 306. Mean distance from the anal verge in the systemic review was 6.3 centimeter, and here it shows that we have significantly ultra-low lesions operated with the mean distance from the anal verge with 3.1. We have, in simple words, operated directly at the anal verge. Positive DRM 0.2%. Our experience 0%, and the positive CRM we have not yet measured in our experience, and the determining factor or determining criteria is the pathological grade or the quality of the specimen, and the systemic review shows that 78% with grade 1 and 10% with grade 2. Our experience 69% grade 1 and 4% grade 2. No difference in the mean harvested lymph nodes, and the post-operative complications. They have done it according to Clavilingo classification, minor and major complications, and it shows that we have a little bit higher minor complications, but a significant lower major complications. 30 days mortality in the two groups was no difference. Operative, I talked about operative technique. The surgical procedure was done in two teams with by two experienced rectal cancer surgeons working simultaneously throughout the whole procedure. One team performed the laparoscopic approach, while the other team performed the transanal. And the positions of the ports are as follows: 12 millimeter port at the umbilical region, and a 10 millimeter port at the planned side of the ileostomy. In the whole world, they do it in 5 millimeter port. We do it in 10 millimeter to enable us to do the laparoscopic ultrasound, intraoperative laparoscopic ultrasound of the liver.
Will you conclude, please? The time is over. Please conclude.
Okay. We do the mobilization and the dissection of the vessels in high-tide technique, and the transanal part. This is the Lone Star trocar to expose the anal canal, and we use the 30-degree optic and the gel point part to introduce the ports transanally, and we do a purse string suture to occlude the anal canal, and we do a circumferential incision in the mucosa, and we prepare our rectum throughout the avascular layer, and this is the the hallmark and the highlight of our procedure is the rendezvous manner when we prepare the rectum until we reach the reflection of the peritoneum, and we meet our laparoscopic surgeons who conducted the laparoscopic part. And this is the meso-rectal specimen. It shows that that it is completely exteriorized transanally, and we drew the anastomosis transanally. And this is our team, transanal and trans-abdominal teams. And at the background, these are hospitals. They come from 2 times per year to our clinic from different parts from Germany and other countries to observe our transanal laparoscopic technique. Thank you for your attention.
Thank you.